Hi, very good afternoon to everyone, and it's my pleasure to welcome you to the first session of our lower limb anatomy lecture series. Uh, this lecture series is designed with a focus on clinical relevance, cross-sectional imaging, and anatomical precision. So we'll explore the structural and functional anatomy of the lower limb from bones and joints to muscles, vessels, and nerves. Our goal is not just to memorize these structures, but to understand how anatomy informs radiotherapy planning, patient positioning, and how it's vital for patient safety, how this knowledge is important for patient safety. Today's session will lay the foundation. So we'll begin with an overview of the lower limbs regional organization, key terminology, and surface landmarks. Yes, this is our study plan. So in the first lecture, we'll cover the surface anatomy and osteology. So in lower limb, we can divide into four regions as per the surface anatomy: gluteal, thigh, leg, and foot. And in the bony osteology, we'll study it as per the our in the upper part we will encounter the thigh bone, the femur, longest bone. Then we will study about the hip bones such as ischium, pubis, and ilium. So patella, tibia, fibula, and tarsal bones, metatarsal bones, phalanx, and also we'll study bony landmarks. Then in the next lecture, we will cover all the major muscles and major neurovascular structures and lower limb movements. Okay, in this slide, you can see lower limb from two different views, one from anterior view and other one from the posterior view. Here we will just try to identify the prominent landmarks and prominent structures as per the surface. And so at the beginning you will be able to identify the iliac crest, and this ASIS anterior superior iliac span is very palpable, so it's a good landmark. Then the person who has done a lot of workout or who is going to gym regularly, so if you look at a person like that, you can see all those landmarks very clearly. Here quadriceps muscles, which includes vastus lateralis, rectus femoris, and then at the distal end you will see the quadriceps tendon, which attaches with the patella, and it continues as the patellar tendon until it's inserted into the tibial tuberosity. It's prominent in your anterior lower limb, so you can palpate from the outside this tibial tuberosity. It's a good landmark, and you can see the veins, superficial veins, especially GSV, the greater saphenous vein. And in the lateral side of the anterior lateral side of the lower limb, you can see the tibialis anterior muscle, and at the distal end you will be able to identify lateral malleolus and the medial malleolus. And this extensor hallucis longus tendon also visible when patient is doing plantar flexion, and you can see the extensor digitorum longus tendons also. So from the back side or the posterior views, you will be able to identify the iliac crest. Then you will see the gluteus maximus muscle, and you can see the gluteal fold here. And in the lateral side, you can palpate easily greater trochanter of the femur. It's a good landmark for the surgical incision. So then you'll see that when you go downward, you will see the popliteal fossa, and when you go down further, you will see the two heads of gastrocnemius muscle, medial and lateral heads, and its continuation as Achilles tendon, and it goes and attaches into the calcaneum. So here from the posterior also you can identify the medial malleolus and the lateral malleolus. So these are the major landmarks what you can see. Okay, now we have set the stage. So let's begin by understanding the structural framework of the lower limb. What we call it the inferior appendicular skeleton. So coming to functional overview of the lower limb or inferior appendicular skeleton. So this lower limb is specialized for locomotion, balance and postural support. These functions are critical not only in daily movement but also in how we position patients during our radiotherapy planning. So it bears body weight and must adapt a dynamic forces. This is why its joint and musculature are so robust and specialized, because it's need to adapt to dynamic forces, as well as lower limb should bear the body weight. So they are, because of this, joints and musculature of the lower limb is more robust and they are specialized. So anatomically, the lower limb is connected to axial skeleton via what? Via the pelvic girdle. This connection is essential for transferring weight and maintaining stability. So through this pelvic girdle, weight will be transferring via the lower limb, and it helps to maintain the body stability during locomotion and standing. So for clarity and clinical relevance, we divide the lower limb into 4 regions: gluteal, thigh, leg and the foot. Gluteal region includes major muscles like gluteus maximus and medius, and this is key for the posture and gait. So gluteal region house for the gluteal maximus, gluteal medius, like major muscles. So the thigh region house for powerful extensors and the flexors, and as well as major neurovascular bundles. So leg is the area between the knee and ankle. This area is crucial for mobility and venous return. So when we go forward, foot is a complex structure for foot has a complex structure for balance, propulsion and weight distribution. So it has foot arches, there are complex rays, complex rows of the metatarsal bones, and so likewise it has a complex structure to support balance, propulsion and weight distribution. On the right, you will see anterior and posterior views of the lower limb with a label diagram. So note the key landmarks like the femoral artery, saphenous vein and muscle compartments. These will recur in both anatomy and our clinical practice also. Let's now shift our focus to the skeletal framework of the lower limb, the foundation upon which all muscular, vascular and neural structures are built. The inferior appendicular skeleton includes key bones from the hip to the toes, each with distinct roles in weight bearing, movement and anatomical alignment. Starting from the hip bone, which is formed by the ilium, ischium and pubis. We move down through the femur, patella, tibia, fibula, ending with the tarsals, metatarsals and the phalanges. Understanding this arrangement is essential for interpreting images, planning radiotherapy fields, and anticipating anatomical variations. In anatomical position, pelvis is tilted forward so that pubic symphysis and the anterior superior iliac spine or ASIS align vertically. It places significant stress on SI joint and their ligaments, which act as shock absorbers and stabilizers during upright movement. Now, consider the body's center of gravity. When we stand upright, it lies just anterior to the S1 vertebra of the sacrum. This positioning allows for efficient weight distribution and balance, especially during locomotion. So in this diagram, it illustrates the hip bone. There are two views, one is lateral view and other one is medial view. So hip bone, which is formed by the fusion of three bones, they are ischium, ilium and pubis. So fusion of these three bones all together make the hip bone. So ilium is colored in yellow color. You can see this is your ilium, and this is your, in the ash color, this is your ischium, and this is your pubic bone. So these three bones fuse together in the acetibulum to form the acetibulum here. So this ilium is broad and it lies in the superior portion of the hip bone and it supports the abdominal organs and serves as a key landmark in surface anatomy. Ilium, the ash color, it is in the posterior inferior part. This ischium form the bony base where we sit on. Then finally the pubic bone, it's colored in red color. So it is in the anterior-inferior segment, contributing to pubic symphysis and forming the pelvic ring. On lateral view, note the acetibulum. This is acetibulum. You can see though this is deep socket that articulates with the femoral head. So this forms the hip joint. So this is a critical site for weight bearing, weight transmission and the joint mobility. So here still another thing, important thing is you can see this notch. This is your greater sciatic notch and this is your greater sciatic notch. So here this is the place where sciatic nerve exit the pelvis. So greater sciatic nerve, and this is a key landmark both in surgery and in radiotherapy planning. The other important landmark is anterior superior iliac spine. This is abbreviated as ASIS. This is your anterior superior iliac spine. This can be palpated from the outside. So this is very important landmark in surface anatomy and also help for the surgical planning and patient positioning. So now we come to the medial view. This is your medial view. Here you can appreciate your obturator foramen. This is a large opening where the most of the neurovascular structures pass through to the lower limb. So this is your obturator foramen. This is a very important landmark. So understanding this landmark is essential for interpreting pelvic imaging and also in assessing in trauma and planning surgical planning and interventional near hip joint. This slide presents two complementary views. On the left, a labeled X-ray image of the pelvis and upper femur. On the right, you can see the anterior view of proximal femur. Let's begin with the pelvis. Okay, you will notice here three major bones forming the hip: the ilium, so pubis and ischium. So they all together form the pelvic bone. So they are together make the acetabulum. This is your acetabulum. So this is a deep socket where your head of femur lies in the houses in this acetabulum. So this ball and socket configuration allows for a wide range of motions, especially for walking, running, and maintaining balance. So now we focus on the femur. The head, this is femoral head, it fits snugly into the acetabulum, and just beneath it lies the neck of the femur. This is your neck of the femur. This is a common site for fractures, especially in elderly population. So the other important point is fovea. This is your fovea. Here you can see the fovea. This is the place for the attachment of the ligaments which stabilize the joints. So moving outward, we see the greater trochanter. See, this is your greater trochanter and this is your intertrochanter, lesser trochanter, and this is your intertrochanteric line. So this is the transition area from the neck to the head to the neck. This is your crest. So these greater trochanter and lesser trochanter are very important place for muscle attachment. So they are very important muscle attachment site. So, and these landmarks are very important in both imaging and surgical planning. On X-ray, you can also identify the obturator foramen. This is your obturator foramen. So this is your ischial tuberosity, and here pubic bone, superior ramus of pubic ramus, and this is your inferior pubic ramus, and this is ischial tuberosity. So these bones make the obturator foramen. So this obturator foramen allows the passage of nerves and vessels to the lower limb. Clinically, this region is vital, whether it's a fracture, hip dislocation, or arthroplasty. Understanding these landmarks help us diagnose, treat, and teach for the teaching with confidence. So this slide presents two components: a table summarizing the feature characteristics and the lateral anatomic view of the bone itself. So let's begin with the overview. Each coxal bone is formed by the fusion of three bones: ilium, ischium, and pubic. So we won't take much time because we already know that. So we'll go ahead, and these bones fuse during the adolescence to meet at the acetabulum. So in the lateral view. So we'll go and we'll see the key landmarks here. So this is your iliac crest, its superior it lies, and it is a attachment site for the muscle, important attachment site for the muscles in the upper margin. And there are special landmarks such as anterior superior iliac spine. We already know you can it's palpable. So as there is an anterior superior iliac spine, there should be posterior superior iliac spine. Here this is your posterior superior iliac spine, and as there is a superior spine, so there should be a inferior spine. So here then you can see the posterior inferior iliac spine, and here this is your anterior inferior iliac spine. So this is your iliac crest. So this area called body ala, wing of the ilium or ala. Then this is anterior superior iliac spine, this is anterior inferior iliac spine, posterior superior iliac spine, and the posterior inferior iliac spine. So these sides serves as the attachment points for muscles and ligaments. So other important point is your sciatic notch. This is your greater sciatic notch. Now we know that. So where the sciatic nerve passes through, then acetibulum, and ischial spine you can see. This is your ischial spine. So this body of ischium, this is your ischial tuberosity. This is the place where we sit on, and the place for muscle attachment also. So, and the pubic body and the rami you can see. So these are important position, and this body of the pubic and ramus contribute to the anterior pelvic wall, and they support the urinary bladder. So now let's shift our focus to the posterior inferior aspect of the hip joint. Posterior and inferior aspect of the hip joint. Posterior and inferior aspect of the hip joint. So this is the bone which lies in the posterior inferior aspect. It is ischium. So this region rich in surgical relevance. Here we see the greater and lesser sciatic notch. This is your greater sciatic notch, and this is lesser sciatic notch. It is separated by the ischial spine. So this is a very important place. It's a gateway. These notches are the gateways for the neurovascular structures entering and exciting the pelvis. So and here you can note this ischial tuberosity. So it's a key weight bearing landmark. It anchors many muscles, especially hamstring muscles, and it's palpable in clinical examinations. And note how the body of ischium, see this is your body of ischium, it's seamlessly joined with the ilium and pubis to form this socket called acetabulum. So it's making the acetabulum. So then the ramus of the ilium, ischium. So this is ramus of the ischium joined with the inferior pubic ramus to form the obturator foramen. So these are very important landmark. So we call this ischiopubic ramus together. Ramus of ischium and the pubic ramus of the pubis, we call it ischiopubic ramus. So these are structural bridge that support the pelvic integrity. Okay, now let's focus our attention to the pubis. It's from the anterolateral part of the hip bone, and anterior part of the acetabulum. So it's a key contributor for the pelvic stability. The pubis forms the anterolateral part of the hip bone and contributes for the anterior wall of the acetabulum. So that is the main role of the pubic bone. Where so it has a body. This is central portion connects the opposite bone, pubic bone, at the pubic symphysis. So it's a cartilaginous joint that allows slight movement, and it's absorbed shock during the walking. So this pubic body joined with the pubic body of the other side to form the pubic symphysis. This is a cartilaginous joint that allows slight movement, and it can absorb the shocks during walking. So other main structure is the superior pubic crema, or abbreviated as PR. It extends upward to articulate with the ilium, and then inferior pubic ramus, it projects laterally and inferiorly to articulate with the ischium, ramus of ischium, to make it ischiopubic ramus, and they are together forming the obturator foramen. So where neurovascular structures pass through. So these are the important point for the pubis. It has a body and rami. Body connects the left and right pubis at the pubic symphysis, and rami, superior rami, connect with the ilium to make the SPR, and inferior ramus connect with the ischium to make it a ischiopubic ramus. So this is your obturator foramen. Let's now examine the superior surface of the pubic bone, which plays a key role in pelvic stability and serves as a reference point in both anatomy and surgery. There are three important landmarks to note. What are they? Pubic crest, pubic tubercle, and pectine pubis. So we'll go by one. So pubic crest is the anterior superior border of the pubic body. The pubic crest, you can see this is anterior and superior border of the pubic body. So this is your pubic crest. So just lateral to it, you will see the pubic tubercle. So this pubic crest serves as an attachment site for the abdominal muscles, including the rectus abdominis muscle. So this is your pubic crest. Just lateral to it, you can see the pubic tubercle, which is a rounded pulp. It's so then pubic tunnel, it's a small and rounded projection located laterally on the pubic crest. So it's a main landmark, and it's a attachment site for this pubic tubercles, attachment site for the inguinal ligament, making it a key landmark in hernia surgery and groin anatomy. So this is your pubic tubercle. This is rounded small projection just lateral to the pubic crest. It attaches with the inguinal ligament, so making it very important in hernia surgeries. So finally we'll go into the pectine pubis. It's the posterior margin of the superior pubic ramus. So here you can see this pectine pubis. So this make the posterior margin of the superior pubic ramus, and it's a part of pubic brim. So this is a posterior margin. Okay, it's provide attachments for the pectineal ligament and contributes to the pectineal iliopectineal line, which separates the true and false pelvis. So this is the important bone landmark in the pubis in the superior surface. One is pubic crest. You can see this is your pubic crest. Then just laterally rounded projection is the pubic tubercle, and this is posterior margin is the pecten pubis. So these are the key landmarks and essential. So these landmarks are essential in procedures like hernia repair, pelvic fracture fixation, and abdominal wall reconstruction. So especially please note that the pubic tubercle is a key reference point in identifying femoral versus inguinal hernias. Yes, okay. Now let's explore the ligamentous architecture and uh, foramina of the pelvis. So here there are two important ligaments. One is sacrospinous ligament, another one is sacrotuberous ligament, and there are three important foramina. So these foramina are key passageways for neurovascular bundles, and also they stabilize the pelvic girdle. So there are two important ligaments. What are they? Sacrospinous ligament. This is your sacrospinous ligament, and other one is sacrotuberous ligament. So they are making these important passageways. So sacrospinous ligament extend from the sacrum to the ischial spine of the ischium. So this converts greater sciatic notch into greater sciatic foramen. So this is your, now this is has become your greater sciatic foramen. So these are great passageway for the neurovascular structures. So following that, other important ligament is sacrotuberous ligament. So it runs from the sacrum. This is from the sacrum to ischial tuberosity. So this form the posterior boundary. This form the posterior boundary for the both foramina, greater sciatic foramina and lesser sciatic foramina. Posterior boundary is formed by the sacrotuberous ligament. So this is need to remember. So together these ligaments transform the notches into the functional foramina, allowing the passage of critical structures like, what are those critical structures passing in these foramina? Sciatic nerve, pudendal nerve, and pudendal vessels, internal pudendal vessels. So in the greater sciatic foramen, this is your greater sciatic foramen. This you can see this greater sciatic foramen. So it's made by the sacrospinous ligament and the posterior bounded by the sacrotuberous ligament. So this is the gateway for the structures exciting from the pelvis to the gluteal region. So especially sciatic nerve. So, and this is your lesser sciatic foramen. It allows re-entry of structure into the perineum, especially the pudendal nerve. So other important foramen, you can remember now we told that there are three important foramen and two important ligaments. So the third foramen is obturator foramen. This is your obturator foramen. It is formed by the pubis and ischium. So this is the your obturator foramen where you get the passage for the neurovascular structures. So these are very important thing. It's formed this for this one obturator foramen, formed by the pubis and the ischium. It's transmit what it gave the passage for the obturator nerve and the vessels. So in anatomical position, the ASIS and anterior pubis lies in the same coronal plane. This is very important arrangement. So the internal surface of the pubis faces superiorly, not anterior. So it faces superiorly. So the pelvic, so because of this arrangement, pelvic inlet is more vertical than the horizontal. This is important to understand the fatal descent. So you see, this is more facing more superiorly rather than horizontal. So these foramina are the key landmarks in nerve blocks, pelvic surgery and trauma assessment. So misalignment or injuries to these ligaments can affect pelvic stability and neurovascular. It also can affect neurovascular integrity. So you should have good understanding about these structures and there is this peculiar arrangement. In summary, the ligaments and foramina of the pelvis aren't just structural. They are gateways and anchors that define the pelvic function and clinical access.